Hello everyone, welcome to my YouTube channel. So in this video, I am going to talk about oro antral fistula. So as you can see in this picture, an oro antral fistula is a communication between the maxillary sinus and the oral cavity through an epithelialized fistula. So what causes this fistula? It is seen most commonly in the post-operative period following a cardiovascular surgery, or it may also be seen after fracture in the antral floor, that is the Leaford 1 type of fracture. This fistula is common following a mucormycosis infection or after a maxillary tooth extraction or maxillary osteomyelitis. It can also be seen in case of maxillary sinus malignancy, which is eroding the floor of the maxillary sinus, or following any granulomatous disorder of the paranasal sinuses. So coming to the various types of fistula, it can be classified on the basis of the size, that is whether it is a small fistula or a large fistula. The small fistula is generally less than 5 mm and the large fistula is more than 5 mm. It can be also be classified as an acute oro antral fistula or a chronic oro antral fistula. In acute oro antral fistula, a patient usually presents with pain, epistaxis, and unilateral nasal obstruction, whereas in chronic oro antral fistula, it is mostly painless and it is associated with nocturnal cough. Coming to the clinical features that are seen in this condition are like fluid entering the nasal cavity upon drinking any fluids, or feeling of rush of air through the tooth socket while breathing. It may also be associated with a voice change, halitosis, epistaxis. We can do a nose blow test to confirm the fistula, where the patient will complain of air leaking through the oral cavity when blowing his nose out. So, in order to confirm the diagnosis, the things we need to get done is an orthopentomogram and a CT paranasal sinuses. So here you can see in the CT the paranasal sinuses, the location of the fistula that is in the floor of the maxillary sinus. So treatment, it depends on the size. If it is a small sized fistula like less than 5 mm, it most often closes spontaneously. We need to treat the patient with IV antibiotics to prevent any associated infection. However, if the defect is more than 5 mm, it is less likely to get closed spontaneously. So in that condition, we need to do certain surgical procedures like suturing the gingiva over the defect, or excision of the fistular tract and use of broad-based lingually or facially rotated flap. We can use some buccal advancement flap, we can use parietal rotation flap, or if such flap are inadequate, we can also use a bone graft. So here in this picture you can see that we're using a buccal mucosal advancement flap to close the defect, and in this picture you can see the use of a palatal rotation flap being used to cover the defect. So this chart will help us in knowing the various closure techniques of the oro antral fistula, like use soft tissue flaps, like the local flap, which we most commonly use the buccal flap, the palatal flap, or the fat pad. We can also use the distant flap like the tongue flap. We can use bone grafts if the soft tissue flaps are inadequate. We can take the bone from the retromolar area, the zygoma, the iliac crest, or the chin. Some allogenous materials are also available like the fibrin glue or the dura. We can use collagen, gelatin film, and bio-os to close the defect. Some synthetic material like gold, aluminium, titanium, hydroxyapatite have also been used to close the defect. And there are some other techniques also which are being developed for closure of this defect. So that's all regarding oro antral fistula. Uh, I hope you find this video useful. Thank you.